Welcome to another edition of Surgery Live. Have a great topic today with a couple great presenters. We're so fortunate and thankful to have an expert like Dr. Amy Lightner here with us today to present on dysplasia in an ulcerative colitis patient, along with Dr. Nick Berger, one of our rock star fellows here at Cleveland Clinic. So with that, I will kick it over to Dr. Lightner and we'll get it going.
Thank you. Thank you for having us today. We wanted to bring a case to discuss, given that this seems to be a controversial topic, that there's been a lot of evolution in the recommendations of how we manage dysplasia in the setting of ulcerative colitis. So we wanted to highlight some of that decision making and hopefully facilitate an active discussion. And Dr. Berger's done a great job putting this together. And so I'll have him start with the patient presentation.
Thank you very much, Dr. Lightner, Dr. Rosen, and everybody here with Surgery Live. We'll start with our case presentation. So this is in colorectal clinic. We have a 32-year-old man who presents with a history of ulcerative colitis since age 16. He's fairly well controlled on infliximab and 6-MP, and he had left-sided pochoscopy at diagnosis. He has no family history of colorectal cancer. Specifically, he was sent over by his GI doctor because he had a friend that presented with dysplasia, and he was told it's a precancerous lesion. And so he was wanting to know about his risk and possible surveillance. So our first discussion point is then when to start dysplasia screening and how often. And I'd like to ask either Dr. Lightner or Dr. Rosen to give us maybe a spiel that they tell their patients when they present with this.
So patients with inflammatory bowel disease, especially if they've had longstanding chronic inflammation, we know that they're at somewhat increased risk for development of neoplasia. And so most recommendations suggest to start with the first screening colonoscopy 8 years from the time of diagnosis. And that has a little bit of variability because you also have to consider risk factors. So if a patient has concurrent primary sclerosing cholangitis, which is a liver extraintestinal manifestation of IBD, we would want to start that screening at the time of diagnosis. The other thing that comes up is you may have a patient that was diagnosed, let's say 4 years ago, but on their history, when you're talking to them, they say that they've actually been having symptoms for a lot longer than that. It's just that they didn't happen to be diagnosed until 4 years ago. So some of those things get taken into consideration. But I think across the board, most of the guidelines would state that 8 years from time of diagnosis, you can at least initiate with a screening colonoscopy.
Okay. So that's exactly what happened with our patient. He was advised to begin screening colonoscopy as soon as possible. I'd like to highlight just some of the society guidelines that exist. There is a fair amount of variability both in Europe and here in the United States. There's a fair consensus about beginning 8 years after diagnosis. These are the European Crohn's Colitis Organization guidelines from 2019. And as Dr. Lightner mentioned, there's I mentioned low risk, intermediate risk, and then high risk patients. With those patients with PSC, stricturing, dysplasia on recent colonoscopies fitting into a yearly surveillance category. And then patients with an increased risk of colorectal cancer or extensive inflammation on a 2 to 3 year screening colonoscopy, surveillance colonoscopy, and then every 5 years. The American Society of Gastroenterology and Endoscopy guidelines are fairly similar. Annual screening and diagnosis, there's an agreement for primary sclerosing cholangitis, active inflammation, the history of dysplasia, colorectal cancer, first degree relative, and then anatomic abnormalities. They also make mention of average risk patients on a 1 to 3, and then for patients who every 3 years have 2 normal exams, that those patients can go out to no sooner than every 3 years. And here's a table that kind of summarizes all of this. You can see there is a little bit of variability that exists with both ECHO, the British Society of Gastroenterology, AGA, and the ASGE guidelines. And it's important to ask, okay, so why is this important? And from a fellow perspective, it's a significantly increased risk of colorectal cancer. I think we all are fairly familiar with this. A lot of the old retrospective data would suggest that patients are at a 2% risk of colorectal cancer at 10 years, 7 to 8 by 20 years, and up to 15 to 18% at 30 years. And there is some new data, retrospective multi-institutional data that suggests that this risk may be less, though it is worth mentioning that this is still an increased risk. And as have been mentioned, additional risk factors include extent of disease, the duration of disease, so younger age of diagnosis means a longer progression of disease, and then associated primary sclerosing cholangitis is up to a 4-fold increased risk. And of course, family history of colorectal cancer can also confer an increased risk, of course. So cancer risk with dysplasia, this data is based on a Mayo study of 2,100 UC patients undergoing total abdominal colectomy or total proctocolectomy. 141, so about 7 to 8% of these patients had low-grade dysplasia or high-grade dysplasia on random biopsies. And colorectal cancer was identified in 2 and 3% respectively of these patients. There was a 3% risk of colorectal cancer in patients without pre-op dysplasia. And in 2019, a retrospective multi-center study found that 14% rate of progression of high-grade dysplasia to colorectal cancer over 15 years. So it's very important that we catch these patients, we surveil them appropriately, just as we would surveil patients now in the United States greater than age 45 with a screening colonoscopy. So I'll turn it over back to our experts. So how should he be screened? We know of a few different colonoscopic modalities that exist, and I guess what are his options?
Before going to that question, I think one thing to highlight from the literature on dysplasia, or one challenge from the literature, is that most of the studies are retrospective in nature. We don't have a large population of patients that have been followed longitudinally, prospectively for 20 or 30 years to really see from surveillance to surveillance to surveillance over a period of several endoscopies what actually happens with the natural progression of dysplasia. Either a lot of those patients get lost to follow-up or they may have surgery. So it's really hard to get a sense of true progression, which is why I think we see some of the variability that we do in the literature. We looked at our own data here over a large number of colonoscopies, over 20,000. And the challenge is that we didn't necessarily have several colonoscopies from the same patient over a long duration of time. So I think that progression of dysplasia to cancer or low-grade to high-grade, we've seen this variability and perhaps lower rates due to the way that the data is collected. So I just wanted to ask Dr. Wexner, in terms of when you're doing surveillance on these patients with IBD, how do you surveil them? I know that some of the guidelines will state, random biopsies every 10 centimeters. Other guidelines are now suggesting visible lesions. What's your approach with this?
That's a great question, and I believe it's both, that it should be every 10 centimeters as well as anything that's suspect. Now, the question is, when you have a patient with countless number of pseudopolyps, I mean, obviously you can't biopsy every pseudopolyp, but something that really looks like it could be a DALM, could be a villus adenoma, sure, those areas require additional biopsies from more than one sample representative areas. So it's actually both. I wouldn't do either or.
Yeah, and you bring up a good point on the pseudopolyps. This was brought up in a discussion we had a couple of nights ago with our gastroenterology colleagues, is that if patients have a lot of pseudopolyps, are they at increased risk of having dysplasia or malignancy there? And the carpeting of pseudopolyps doesn't necessarily increase the risk of having dysplasia actually at that site. However, it makes surveillance more difficult in that it makes it more difficult to identify a lesion that may be otherwise visible without pseudopolyps surrounding it.
Oh, that's an excellent point, and that's a discussion that sometimes I'll have with patients. That there's no dysplasia, but there's no way we can figure out if there is dysplasia because the entire colon is covered with pseudopolyps. Any one of them could be problematic, or there could be something under the surface of one of them. We just don't know, but it becomes sometimes, not often, but sometimes an indication for surgery is inability to properly survey.
What do you think as well, Dr. Lightner, you guys mentioned two things on those data slides that Dr. Berger mentioned. One, You touched a little bit on the fact that, those studies are tough to measure the progression because you have talked about a 3% risk of cancer when there was no no dysplasia, and 2% for low-grade dysplasia and 3% for high-grade dysplasia. So it sounds like you think those numbers being the same are not indicative of really truly measuring the disease process that's going on because it's retrospective and you don't have routine colonoscopies. Does that sound about right?
Yeah, it's challenging. There's one series from St. Mark's that actually put together a nice cohort of patients and followed them prospectively over time. But that's one of the few series with a large number of patients followed prospectively. So a lot of this data just comes from simply retrospective review, and it's limited. We don't have a lot of population-based data sets where we can follow patients longitudinally to see what the natural progression is. And a lot of the patients end up going to surgery. So it's unclear as to what would necessarily happen. The paper at Mayo, when it looked at high-grade dysplasia and low-grade dysplasia and what was found at the time of colectomy, that was really looking at synchronous lesions, you could argue as well, because you have a patient with low-grade dysplasia, you take them to colectomy and what was found at that time, so at that snapshot in time. So that also isn't a true progression of what happens with dysplasia when you leave it in situ.
And is this new data showing that the risk may be less? Do you think that has to do with all the biologic medications we have now, and could that be participating?
Yeah, so that's come up as a question. We know that chronic active colitis, or we think that having chronic inflammation increases the risk of dysplasia formation. So I think that the argument is made that if we can keep luminal disease well controlled and minimize the amount of inflammation, that then the risk of progression to dysplasia may be lower. Others have said, well, perhaps in the era of biologics and so many different medications we can now use to treat colitis, that patients are having more long-standing disease. So they might have a longer duration of disease with mild symptoms because they cycle through a number of biologics. So I've seen that argued both ways. We really don't have data to suggest that the introduction of biologics have changed the rates of dysplasia.
All right, let's get back to the presentation, Dr. Berger, and see what you guys got.
Can I just ask a question of Dr. Wexner and Dr. Lightner? This is Amina Wong. Is there a role for chromoendoscopy?
Yeah, I think there is, and apologize that I neglected to mention it, but yeah, I kind of crossed my mind that I didn't say it, but yes, I think there is. I don't know if Dr. Lightner has any difference of opinion, but I think that's one of the values.
Yeah, we're going to go over that in the next couple of slides, but I think, there's been a lot of studies recently in the literature, mostly in the GI literature, looking at the use of chromo versus high definition white light and what should we be using. And in terms of chromo, do we need to use spray chromoendoscopy, and what are the actual logistics in using spray chromoendoscopy and how that adds time to the procedure. So we'll go over that in the next few slides, but I think there's been a lot of literature looking at that. There certainly is a role for chromoendoscopy, especially if there's a question of visible lesions.
So he underwent high definition white light colonoscopy. He had random 4-quadrant biopsies every 10 centimeters, as Dr. Wexner had touched on. There were no visible lesions at that time, but of course, chromoendoscopy with targeted biopsies can be done in the case of in what's called invisible dysplasia. So, as I mentioned, he underwent HD white light colonoscopy. He had no suspicious visible lesions. He did have random 10 centimeter biopsies taken, and his pathology was high-grade dysplasia in the transverse colon using high definition white light colonoscopy. And so he was referred to a specialized endoscopist for chromoendoscopy. So I wanted to touch a little bit just on chromoendoscopy since we've mentioned it. The cecum is intubated with water and suction, and then indigo carmine or methylene blue can be mixed with water, so diluted with water up to 250, 240 milliliters, and then in 20 to 30 milliliter aliquots, as the scope was withdrawn, certain lesions will show up with this dye. So focus on 20 to 30 centimeter segments, and the concentrated dye is applied. And then if a suspicious lesion is identified, an en bloc resection, so endoscopic mucosal resection or submucosal dissection can be performed. Then the important thing is also to mention that biopsies of the surrounding mucosa should be done. So we need to make sure there's not dysplasia that's outside of the area of resection. It is fairly technically challenging. The guidelines recommend doubling the amount of time for colonoscopy to perform chromoendoscopy. And in terms of lesion nomenclature, we've touched on visible and invisible lesions. And the majority of ulcerative colitis related dysplasia based on retrospective reviews is visible. And the Paris classification polypoid or non-polypoid. And so slightly elevated, flat, depressed, and ulcerated lesions would fit into the non-polypoid classification. I have a slide on the next slide that illustrates this. And most societies are no longer using dysplasia-associated lesion or mass terminology. So this is the Paris classification. We can see that what we typically think of as polyps fit into the polypoid type, and obviously the non-polypoid would be characterized as superficial, elevated, flat, superficial, shallow, and then excavated or ulcerations. Getting back to our patient, so he had a visible lesion, non-polypoid, slightly elevated, that was identified in the transverse colon. This was able to be fully resected endoscopically, and then there was a in this case, you would consider a tattoo, and then pathology was high-grade dysplasia with negative margins and no dysplasia in the surrounding mucosa. And so I would ask our expert panel, surgery versus surveillance in this case, and if surveillance, what would be the interval?
So just a couple comments on going back to that chromo question. The literature in GI suggests that high definition white light is equivalent to chromoendoscopy in most of the papers. There are a couple papers suggesting that chromoendoscopy is superior for visualization of these visible lesions. The reason why it adds time, and logistically, if you could simply use the spray bottle and put the dye into the spray bottle and then be able to use basically a foot pedal while you're doing the endoscopy, that would save a lot of time. But because of the way that we sterilize the scopes, most of us have to actually feed in a catheter to then do the spray. So then if you see a lesion, you're taking that catheter out and then putting biopsy forceps in and going back and forth. So it adds quite a bit of time. So a lot of people in their day-to-day practice will use high definition white light. Certainly a lot of our gastroenterologists use that here. I think that if a visible lesion is found or if dysplasia is found, a lot of times they then are referred for chromoendoscopy after the fact. This new classification of lesions, of focusing really on just the simple visible versus invisible, really has to do with how we are managing dysplasia. So there used to be a lot of different nomenclature that was used as ways to identify and define these different lesions, but now we simply think of it as, is it visible or is it invisible? And if it is visible and completely resected, that has certain implications. If it's invisible, that has other implications. So maybe we can go back and ask Dr. Wexner again. In this patient who had a visible lesion, completely resected, comes back with high-grade dysplasia. There's really limited inflammation, and you've biopsied all the surrounding area, and there's no other dysplasia that is found. What would you recommend for this patient when they come and see you in clinic?
Just remind me the age and the length of history.
Oh, how long has he had disease?
And the age of the patient.
The patient was 32. He was diagnosed at age 16, so he has 16 years.
Yeah, I mean, I would certainly counsel him that although the lesion in the instant case has been removed and we can try and stay on top of it and he has no other disease, he's at very high risk of something else coming down the road. And I think he's probably wiser to deal with it in a completely favorable setting where it's not yet malignant, it's not yet multifocal, and he could get a good operation performed in an elective setting while he's not sick with disease and immunosuppressed, and that's the best possible outcome. But if he was absolutely obstinate against it, we'd have to closely follow him and survey.
Yeah, exactly. And then I see that Dr. Gorgon is on, and I'm not sure, I think he's on his phone, but I'm not sure, Dr. Gorgon, if you can make a couple comments on your use
Sure.
of ESD for these lesions and kind of what you think about when you see a lesion, whether you think that ESD will be possible as a way to remove a larger visible lesion.
Absolutely. Thank you very much, Amy. Great discussion. I'm sorry, I'm at a dentist office, but I can see you guys, and I saw the pictures and presentation as well. I agree with everything you said, and you and I, we discussed about these as well in the past. Definitely, like you mentioned, the literature is from before for chromoendoscopy, and most of the studies always compared standard light with chromoendoscopy. Therefore, always chromoendoscopy was superior compared to standard light endoscopy. But now in this day and age, with high definition, extreme, like even extra zoom times 5, with the most modern colonoscopies, high magnification, our quality of evaluation for these lesions is way superior. So really, with the push of a button, we can switch between and toggle between MBI and virtual chromoendoscopy versus spray endoscopy. And most of us use at this time because of that virtual chromoendoscopy, much more practical. In terms of the resection, I agree. I think the bottom line is, like mentioned also, the surrounding area is free of inflammation. This is more like a quiescent colitis. So the patient has this isolated areas. Despite the fact the patient has chronic ulcerative colitis, it's not necessarily like super active. That needs, that is inevitable that this patient's going to go to proctectomy pretty soon. These patients are, I think, very possible to manage with these, like endoscopic submucosal dissection and removal of these isolated lesions. But like Dr. Wexner mentioned, if someone has more diffuse disease or metachronous lesions, potentially some other areas, this is no-brainer. I mean, we can maybe buy some time with local excisions and ESD of these areas, but it's sooner or later they're going to progress more disease unless GI doctors come up with some sort of a medication that will slow down the process. So I think that comes down to, but certainly ESD in these quiescent colitis patients, more isolated lesions, I think becomes really readily available. And I think we are going to more and more manage patients with high-grade dysplasia, of course, cautiously with warnings. Thank you for allowing me to comment.
Dr. Lightner, why do we always teach our fellows to biopsy the surrounding mucosa? Is it much higher that you find invisible dysplasia around a lesion in ulcerative colitis than with random biopsies looking for invisible dysplasia?
Yeah, there seems to be this area of dysplastic change. And so even if you have an area that looks elevated or an area that's almost carpeted, sometimes it'll look like you have a carpeted area, and then there'll be little areas outside of that that also look slightly elevated. And so the challenge then becomes you have more of a surface area that is covered with this dysplastic change, and then it's not realistic to be able to excise all of that adequately and remove all the dysplasia endoscopically. So they always recommend that biopsy that surrounding area. But I definitely think the guidelines have changed really, this visible and invisible concept. And so most of the GI literature now says if a lesion is visible, which again, retrospectively, most lesions are now visible with advanced endoscopic techniques, is if it's visible and it's completely excised and there is no surrounding dysplasia, that ongoing surveillance is appropriate. But as Dr. Wexner said, to make sure the patient's going to be compliant with this and actually have surveillance at regular intervals, because it is really important once dysplasia is found that they are monitored closely. So I'll go back to Dr. Berger to facilitate more of this case.
So consistently with the newer GI literature and what Dr. Gorgon was mentioning, he underwent a surveillance colonoscopy, did re-present 2 to 3 months later. He had no dysplasia at the previous margin or on random biopsies. He was surveilled then, again, at 3 years. He had no visible lesions and random biopsies were taken. And the pathology at that point showed high-grade dysplasia, multifocal invisible lesions on both the right and the left side and the surrounding mucosa. And so in this case, then, what would the recommendation? I think we are moving toward this and have already touched on the possibility of what's next.
So I think when this invisible dysplasia comes up, the question becomes a lot more challenging, and it becomes if they have invisible unifocal low-grade dysplasia, is that different than multifocal, and unifocal high-grade, is that different than multifocality? So I think that this question of invisible dysplasia is tricky. Kind of for time's sake, if there is invisible dysplasia, the recommendation is certainly to have further endoscopy with, again, advanced techniques, including high definition or chromoendoscopy, as was discussed, to make sure that there are no visible lesions where this dysplasia is coming from. So the idea is if you have invisible dysplasia, that you should go on to have advanced imaging techniques to see if this dysplasia was actually arising from a visible lesion, which can be excised. So we can consider in this case, the patient was using advanced endoscopic techniques. There was still the presence of this invisible dysplasia found on random biopsy. So I think Stefan Hollabar is as well. Stefan, do you want to comment on what the GI literature says on this topic?
Yes, I think, obviously, if you can't see something, you don't know what you can't see. And so invisible dysplasia is much more concerning and harkens back to the older literature, which suggests that these patients have a genetic field defect in their colon that's caused by the chronic inflammation. And that's why patients who have longstanding disease for 20 or 30 years are at increased risk. So I think invisible dysplasia is much more of a indication for surgery for a prophylactic colectomy to prevent degeneration into colorectal cancer, which we obviously want to prevent in these young patients, mostly young patients.
Yeah, exactly what Stefan was saying. So I think the recommendation, invisible dysplasia is somewhat more concerning because we're biopsying these random areas that are not visibly elevated. And the concern is that there's then more dysplasia that is hidden, given that we're sampling a very, very small proportion of the entire surface area. So invisible dysplasia, regardless of focality, regardless if it's low grade versus high grade, the recommendation is still to be seen in surgical consultation for proctocolectomy, given the risk of neoplasia and development of a colorectal cancer in something that we cannot see and cannot completely excise.
And so that's what happened with our patient. He underwent total proctocolectomy with an ileal pouch channel anastomosis. Briefly, some of the surgical concerns given the history of dysplasia and the risk of progression to neoplasia, an oncologic resection was performed, so central pedicle ligation. And then the next discussion point I'd like to ask would be just how to manage the anal transition zone. So we're leaving theoretically some mucosa that still has a propensity for dysplasia and neoplasia. Is there preoperative concerns prior to IPAA for biopsy of the distal rectum for dysplasia? And then what would be the role of mucosectomy? I think from a historical perspective, I read a lot more about mucosectomy that used to be performed, and we don't see that much anymore. I was wondering if maybe Dr. Hull would be on, or maybe Dr. Wexner can give his opinion as well.
I'll defer to Tracy if she's on. I don't know if she's on.
I don't see her on, Dr. Wexner. It'd be great to get your insight on this.
So, the reason that in 1989, David Jagelman and I started performing double stapling, in that same year, actually the same month, we published 3 different articles. One from Leeds, David Johnson. One, I think, was Mike Keithley in Birmingham, and us in Fort Lauderdale. We published on doing double stapling. And the reason was because prior to that time, Mayo Clinic had published a series where they had, I don't remember the number, it wasn't many, perhaps 20 excised pouches. And in a high percentage of those patients, there was mucosa outside the pouch, so in the muscular cuff. And we said, if that's the case, we're not really eradicating all the disease. The patient may get cancer, and they're all leaking at night, and they're having incontinence, and they're having high rates of sepsis and transfusions and stuff from performing the mucosectomy. Why not just leave it and we can survey it? And it used to be very hotly debated. I mean, you couldn't have a single meeting at ACS, ASCRS, anywhere without hearing about the mucosectomy, non-mucosectomy debate. But over the years, people realize that, in fact, it's better that you can see the tissue, you know it's there. You can do biopsies in the office on a periodic basis or endoscopy, wherever you like. And it's very rare you have to do an excision and a completion mucosectomy for that reason. More likely, it's the fact that, unfortunately, double stapling has allowed the occasional pouch surgeon to perform pouch surgery because it is much easier. And so now we're doing pouch advancement because what's called pouchitis is really residual proctitis from a long cuff, different issue. Preoperatively, I do think it's important to do some targeted biopsies of that area in somebody like this patient so that you can hopefully exclude that there's already dysplasia present. But again, I absolutely would endorse double stapling. I like to know what's there. I'd like to see it and biopsy it later on rather than, deluding myself into thinking I've eradicated all of the mucosa. And in fact, over the years, patients have come in with cancers arising in the muscular cuff from residual islands of mucosa.
Yeah, exactly. Thank you for highlighting that point. And then I'll turn it back to Dr. Rosen.
Yeah, I mean, personally, I agree with the comments that Dr. Wexner was stating. I also get concerned if you do a mucosectomy, if you haven't gotten it all, and then something gets scarred over and covered up, and it's growing underneath where you can't quite see. I'm the same way in terms of some mapping biopsies to make sure there's no invisible dysplasia prior to surgery, and then I do my pouches double stapled as well.
Patient underwent stage IPAA, was double stapled. There was an anal transition zone that was left, and briefly touched on this as well. Does he need pouch surveillance? So Dr. Wexner, of course, mentioned surveying the cuff is probably the most important part about that. So the interval and what is everybody's practice?
Yeah, so I think this is another controversial topic that has reflected in the variability we see in the recommendations for how often to do pouchoscopy. There is some GI recommendations that recommend annual pouchoscopy, others recommend every 2 to 3 years, and some recommend every 5 years. And then there are some societies like the AGA that have no recommendations at all on how often to do surveillance pouchoscopy. I think that now that we have a lot more literature and we have many more years of looking at data in terms of dysplasia of the pouch and of the anal transition zone, we have more data to suggest that dysplasia and cancers are quite rare. And it does seem to be that the patients that are at highest risk are those that had a neoplastic lesion going into their colectomy, which then puts them at higher risk, which intuitively seems somewhat obvious because if patients had neoplasia at the time of their colectomy, then the residual anal transition zone that is left may be at higher risk than a patient that didn't have neoplasia and had medically refractory disease. So I think that a lot of us have moved to doing surveillance pouchoscopy every year in those patients that had neoplasia at the time of colectomy and patients that did not, that had medically refractory disease, that perhaps we do a pouchoscopy at 1 year after their pouch formation, but then space out their surveillance to every maybe 2 to 3, and some people even every 5 years. So just to get out of curiosity, Stefan, do you have any comments on your practice on surveillance pouchoscopy?
Yeah, the standard recommendation in practice historically has been to, in an asymptomatic patient, to do a pouchoscopy and biopsy the pouch inlet, pouch body, possibly the efferent limb, and most importantly, the anal transition zone. Harkening back to the comments that were made previously about a patient who's going into surgery to consider a double stapled versus hand sewn anastomosis, our practice here at Cleveland Clinic is typically to take those patients for an examination or anesthesia with endoscopy and, as Tracy Hull says, biopsy the heck out of the anal transition zone. But Amy, your newer data has shown that in terms of how often to perform the surveillance pouchoscopy, is not necessarily every year or every other year, but every 3 years is probably adequate.
Yeah, I think one of the challenges, when we do pochoscopy in the office, sometimes it can be difficult to get really good biopsies of the anal transition zone, especially if they have any element of stenosis in the anal canal, or perhaps they have an anastomosis that needs to be dilated. That sometimes actually getting those biopsies and actually biopsying the anal transition zone well can be a challenge. And I'm not sure, Dr. Wexner, do you have any tips for how you actually adequately get good biopsies of that region when you're doing surveillance?
I think that simpler is better. Doing it endoscopically can be tough because if it's a flexible scope, you can't get the right angle to really get, it's almost perpendicular to get the mucosa that low down. You can use an anoscope, but that's somewhat uncomfortable for the patient. So again, since we started this in '89, a lot of years of doing it and a lot of patients, I find what's actually simplest is to put it in the office. They don't necessarily, unless there's something suspicious, of course, just in the office without an anesthetic, to use the flexible biopsy forceps, but essentially finger guiding it. So pushing the tip into tissue in multiple quadrants, 4 to 6 biopsies around just distal to the staple line. For me, I think it's the most, none of it's comfortable for the patient, obviously, but without the morbidity of an anesthetic or the inconvenience of an endoscopy suite, that type of maneuver can be done in the office where you're really getting decent bites of tissue. Anything else, the problem is it's so close to the anus, if you've done it properly, done your anastomosis, that you put your biopsy forceps in straight, but the mucosa you want is a right angle. So with the flexible forceps pushing the tip, I can create that angle I need. So, one hand I've got on the shaft of the biopsy forceps near the tip, and with the other, I'm literally pushing the tip down and asking nurse open, close, open, close. For me, that's worked. I don't know that many other people use that technique, but it's worked well. So first I scope and look at the area, and then I take the scope out and do the biopsies manually.
I think that just highlights a really good point in terms of not necessarily having to biopsy through the colonoscope or pediatric scope or whatever it is that you're using for the pouchoscopy, because to Dr. Wexner's point, it can be very difficult to get adequate biopsies of probably perhaps the most important area. So I think that using the forceps and your finger to guide it is absolutely a great technique practically.
Unless you happen to have, if Jeff Ponsky's working next door and you can borrow the side viewing ERCP scope or something, the EGD scope, like we use for periambulatory biopsies and polyposis patients, that could work too, but I think it'd probably be a bit costly.
Yeah, exactly.
Absolutely. So thank you very much for the discussion. I think we touched on a few of the points in the next few slides. A lot of this data on pouch surveillance is based on retrospective low number studies. So it is worth mentioning, though, that we published recently our experience with surveillance pouchoscopy. And when I say low numbers, we have a fair number of patients, but then just the rate of dysplasia in the pouch, in the anal transition zone, and then cancer arising from the pouch and the transition zone is fairly low. But it does seem as if our data suggests, as has been highlighted, that cancer arising from the pouch is low, but the transition zone is potentially high for the reasons that I think Dr. Wexner had mentioned, these long cuffs, which may be prone to cuffitis, and then progression to dysplasia and neoplasia. So I would like to thank everybody for the opportunity to discuss that. I think we learned a few nice technical points as well. So the final, I guess, part of the case presentation is surveillance pouch endoscopy was performed every 2 to 3 years, and the patient 12 years post-IPAA then develops high-grade dysplasia of the anal transition zone. And how would our experts manage this?
So I think this is a tricky topic and maybe a conversation for another surgery live, given we are running short on time. But I think in general, if there is dysplasia found in the anal transition zone, that is very concerning. And also to highlight some of Dr. Wexner's points, some of the mucosal islands of tissue can be covered when we bring the pouch down. So when there's high-grade dysplasia, we certainly at least would take the patient back and do several biopsies of that cuff area see if any lesions are actually visible lesions. Again, going back to that point that if dysplasia is found in a visible lesion and completely excised, you can continue surveillance. But I think that the conservative approach, and something that really can't be argued against, would be to recommend pouch excision when we find high-grade dysplasia or multifocal dysplasia in the cuff, because patients that develop cancer in the cuff or in the pouch, the prognosis is generally very poor. So I think that a lot of people would argue that a pouch excision at the time of finding dysplasia, certainly multifocal dysplasia, is the best approach for the patient to prevent having a poor outcome or a poor prognosis.
Great. One question before we wrap up here for you, Dr. Lightner and Dr. Hollabar. Do you guys ever use calprotectin levels when you're surveilling these patients with UC to help? Does that ever guide your management whether to continue surveillance versus surgery?
So I generally think of fecal calprotectin levels more so in monitoring disease activity. So if you have a patient that is medically refractory and you get a fecal calprotectin and then you initiate a change in your medical therapy, perhaps a new monoclonal antibody or a new a JAK inhibitor or a new medical therapy, that then after they've initiated that medical therapy, you may follow fecal calprotectins as a way to monitor disease activity, especially in Crohn's disease. We've seen that fecal calprotectin correlates well with endoscopic disease activity. So in my own practice, I think of calprotectin more as a monitoring of disease activity, especially in Crohn's disease. I don't know, Stefan, if you have other thoughts on that.
Yeah, I would agree. Fecal calprotectin can be used for basically similar to a CRP in tracking the degree of inflammation in Crohn's, coloproctitis, or ulcerative colitis, but doesn't necessarily have a role after a pouch is constructed, nor in small bowel Crohn's disease.
Fantastic. Well, we're over time, so I'm going to wrap things up here. Such an exciting topic with a great discussion. Thanks so much for being here, everyone. Fabulous presentation from Dr. Berger and Dr. Lightner. Thanks for stimulating such a great conversation. As a reminder, we meet every second, third, fourth, and fifth Friday at 6:45 to 7:15. We'll be right back here next week. Dr. Magnuson is going to be presenting on the management of persistent pilus ascites following neuroblastoma resection in our pediatric surgery day led by Dr. Anthony DeRoss. And again, I'd like to thank our sponsor, Medtronic, for helping support us. So thanks again for joining us. Sorry for running a little late, and see you next time on Surgery Live.